Hi guys, it's me, Professor D, and welcome back to my channel. On this video, we're going to be doing part 2 of the Peds questions that we were practicing for NCLEX, ATI, HESI, okay? If you haven't done so already, make sure you guys check out part 1. And as always, if you want to support this channel, please don't forget to go ahead and press that like and subscribe button below. Please share my videos with any friends or classmates you know that would benefit from this teaching. So guys, without any further ado, let's get started. First question. A 16-year-old brought to the emergency center with a crushed leg after falling off a horse. The adolescent's last tetanus toxoid booster was received 8 years ago. What action should the nurse take? A. Dispense the tetanus antitoxin. B. Prepare human tetanus immune globin. C. Administer tetanus toxoid booster. Or D. Delay the tetanus toxoid booster until due. If you guys are new to my channel, I know I go a little bit fast. Just go ahead and press that pause button to give yourself a chance to finish reading the question and think of your answer. And when you think you're ready, just press the play button and we'll resume. Okay, guys, so the correct answer is C. Administer tetanus toxoid booster. So, okay, guys, if the patient had already gotten their tetanus shot, they shouldn't get a booster for another 10 years unless they have an injury such as a crushing injury, a severe trauma injury where they'll be exposed to metals, soils, right? Burns, and of course, let's see what kind of injury this patient has. I'm sorry, I got to go back to the question. Okay, so they fell off a horse. So this is a very traumatic injury, guys. Anything, you know, that would involve the patient being in contact, that open area being in contact, like I said, with dirt, soil, stool, saliva. Guess what? They'll need another booster, even if it's been less than 10 years. So that's why you're going to give them the booster, even though it's only been 8 years. That's why they're getting the booster, okay? Next question. A 17-year-old boy with diabetes mellitus tells the school nurse that he has recently started drinking alcohol with his friends on weekends. The most appropriate action by the nurse is to A, tell him not to do this. B, ask him why he's drinking alcohol. C, teach him about the effects of alcohol on diabetes and how to prevent problems associated with alcohol intake. Or D, recommend counseling so that he understands the serious consequences of alcohol consumption. And guys, the correct answer is C. Teach him about the effects of alcohol on his body and how this patient can avoid those types of problems. How old is he? Let me go back to the question. He's 17 years old, so he's old enough to understand. And so what happened when you teach that patient, you're empowering them to make that right decision, because especially, let me tell you something. When it comes to, remember how I taught you that the work of the child is play? Well, the work of the adolescent, of the teenager, is socialization, okay? So at that age, it's very important to them what their peers think about them. It's very important to them not to stand out in any way. It's important for them to be part of the group, okay? That is that age group. So when you explain to them what effects alcohol has on them, and one of those things, guys, I've said it to you before, I'm a pediatric family nurse practitioner, okay? So this is my specialty. Let me tell you, one of the things that I do, I teach my teenagers that are diabetic. One of the things I do is I teach them about the effects of alcohol in their disease process. And one of them is that down there, okay? Exactly. So teaching them, that's going to be the best deterrent. You can't force that teenager to do what they're supposed to. But when they're armed with the knowledge of what may possibly happen if they don't do what they're supposed to, the chance is more likely that they will be compliant. Next question. An 18-month-old child returns to the unit following a cardiac cath with a cannulated femoral artery site. Which intervention should the nurse implement? A, teach the parents how to ambulate the child in the room safely. B, show the parents how to hold the child with the extremity extended. C, restrain the child's lower extremities for a minimum of 4 hours. Or D, place the child in a prone position to apply pressure to the site. And I'll give you a moment to think of your answer. And the correct answer is B. You want to show the parents how to hold the child with the extremity extended. Guys, think about it. That cannulated artery site, guess where it is? Right by the femoral arteries, right by your groin, right? So you want that area where that cannula is being inserted, you want it extended. You don't want it flexed at all. You don't want anything messing with that site. So that site, you want it extended. You see choices A, C, and D, those actually increases the patient's risk for complications. So you don't want to do that. You want to make sure the site, so whether it's the left or the right, but that whichever site that they inserted that cannula right near that groin area, you want to keep that leg extended. Next question. An 18-month-old is admitted to the hospital with possible Hirschsprung's disease. When obtaining a nursing history, the nurse asks about bowel habits. What is the description of the disease? A, foul smelling and fatty. B, biocolored and watery. C, semi-solid and yellow. Or D, ribbon-like and brown. And I'll give you guys a moment to think of your answer. The correct answer is ribbon-like and brown, guys. When you think of Hirschsprung's disease, I want you to think of ribbon-like, okay? So what's happening in Hirschsprung's disease? Why do I feel like I did this question with you guys already? I just taught GI Peds with one of my classes, so that might be it. Okay, anyway, with Hirschsprung's disease, what's happening is they're missing a portion of their bowel, not a portion of the portion of their bowel, they're losing that motility. Nothing's moving. And the reason for that, there is something in the bowel that speaks to the brain. So the brain's like, okay, you got feces in the stool, time for peristalsis. What's peristalsis? When your GI tract is contracting. And that's what makes the poop go all the way through your GI tract and the person poops it out, right? Well, I'm trying to, don't remember the name of it, it'll come to me. But whatever the name of that cell is, they're missing it in the gut. So there's no communication from the gut in the brain. So the brain's not telling the gut to increase the peristalsis, so nothing's moving. And so after a while, what you see, especially near the rectum, it's this small. So imagine the poop trying to get out of a rectum that is what? This small. It's going to come out really skinny, and that's why it's called ribbon-like, because it kind of is skinny like a ribbon, right? Let's look at our other choices. You have A, foul-smelling and fatty. You're going to see this in cystic fibrosis. Remember cystic fibrosis? That's where that patient is producing way too much thick, viscous mucus plugs, right? Those mucus plugs are going to the lungs, but where else are they going to? They're going to the pancreas and even in the GI. The reason that you see the foul, smelly, and fatty, remember what happens in the pancreas. Besides insulin being made, isn't that where your pancreas, well, I gave you the answer, pancreatic enzymes. Aren't those where the enzymes are produced, right? What do those pancreatic enzymes break down? Fat. So think about it. If a patient has cystic fibrosis, they're making all these mucus plugs in their pancreas, right? So they're not able to make those pancreatic enzymes. Do you think that fat's being broken down? Nope. So where do you see the fat? It's got to come out somewhere. It comes out in their feces, in their stool. And that's why you're going to see the foul smelling and fatty stools. That fat is coming out because it was never broken down. Next choice, semi-solid and yellow. You see that in breastfed babies, and that's actually a normal colored stool in babies who are being breastfed. And, lastly, our answer, which was ribbon-like stool. Okay, next question. As part of the physical assessment of children, the nurse observes and palpates the fontanelles. Which child's fontanelle findings should be reported to the healthcare provider? A, a 6-month-old with failure to thrive that has a closed anterior fontanelle. B, a 24-month-old with gastroenteritis with a closed fontanelle, a closed posterior fontanelle. C, a 2-month-old with chickenpox that has an open posterior fontanelle. Or D, a 20-month-old with hydrocephalus that has an open anterior fontanelle? And I'll give you a moment to think of your answer. Okay, the correct answer is A, the 6-month-old with failure to thrive and they have a closed anterior fontanelle. That fontanelle should not be closing until about 18 months. So you're going to call the doctor, because whenever you see a question saying, when do you call the doctor? Really what they're saying is which one is wrong, that you would need to call the doctor, because you never call the doctor when something's going right. If something's going right, the therapy's working, right? Let's look at our other choices. B, the 24-month-old with a closed posterior fontanelle. That's good, because guess what? That fontanelle is supposed to close between 1 to 2 months. So that's normal. We're not going to call the doctor for that. C, a 2-month-old with chicken pox that has an open posterior fontanelle. And that's still fine because there's still time for it to close. And then you have D, a 28-month-old with hydrocephalus that has an open fontanelle. And so the only one that you are going to go ahead and call on this is going to be the 6-month-old that has a closed anterior fontanelle. Excuse me. Next question. At which point during the physical exam should a child with asthma be assessed for the presence of intercostal retractions? A, inspiration. B, coughing. C, apneic episodes. Or D, expirations. And I'll give you a moment to think of your answer. And the correct answer, guys, is inspiration. So I want to explain to you guys what's happening. Think about it. That patient has asthma. And what's asthma? Asthma is when a patient's having airway obstruction due to what? There's a lot of what? Constriction of that airway going on, right? So what's happening is that patient can't breathe. They're trying to breathe. They're trying to take a deep breath. But there's so much constriction in that airway, they're not able to. So when you see those sternal retractions, those are those muscles that are trying to help the patient get in air that they cannot do so, okay? So usually when you see the intercostal retractions, it's going to be with inspirations. Now, something else I want to bring to your attention about asthma. Asthma is not the same as COPD. It's separate from COPD. And you guys, I have to make that clear for you guys, especially in peds, okay? So asthma is reversible. COPD is not, okay? In asthma, a patient can be having an asthma attack and boom, you give them a SABA, a short-acting bronchoagonist such as what? Albuterol. And all of a sudden, the airways open up and the patient can breathe, right? But COPD, such as bronchitis, such as emphysema, it's not reversible. Matter of fact, those two are what we call progressive. That means as time goes on, it gets even worse. Okay, so that's another very important distinction that you guys need to know. What else? Let me give you some other important things that you guys need to know about asthma. When it comes to asthma, patient must always have a SABA, which is, like I said, your short-acting bronchoagonist, okay? That's called your rescue medication. They need to have that, and they need to keep it with them at all times because they never know when they're going to have an asthma attack. And those SABAs work immediately. That albuterol kicks in immediately, okay? Now, if a patient has severe asthma, they might need a maintenance medication, something just to keep them going and to prevent them from having an asthma attack, okay? That's what's known as a LABA, long-acting bronchoagonist. Now, those LABAs, those are given twice a day regardless. Patient feels good, they don't feel good, they take that twice a day. The SABA is the one, that's your rescue medication. That's the one that the patient takes the minute that they're having an asthma attack that they can't breathe, okay? So those are some very important differentiations I want to make sure that you guys knew about. Next question. A burnt child is brought to the emergency room. In estimating the percentage of the body burned, the nurse uses a modified rules of 9. Which part of a child's body is calculated as a larger percentage of total body surface than an adult's? A, the head and neck. B, the arms and chest. C, the legs and abdomen. Or D, the back and abdomen. And the correct answer is A, the head and neck. Why? The head and the neck of a child, proportionately speaking, is much bigger than that of an adult compared to their body. And this is why, guys, there's so many issues with the smaller children falling and drowning into a pool. What's happening? Because they're so small, remember, their head and neck is much bigger compared to the body than the adult. When you're an adult, your head is proportionate to your body. But with the kids, here goes that big old bobblehead in the small little body, right? So the child is running and running and running, and they come up to a body of water. They know the water's dangerous. They want to stop. But remember, they were running. But as soon as they try to stop, that big old head, right? The head's way bigger than the body. What happens? Bloop, they fall right in. So when you're doing rules of 9 and you're trying to calculate how much of the body's burned, you have to really alternate that number. Why? Because the child's head and neck is bigger in proportion to their body than that of the adult, okay? Next question. A child breaks out with varicella infection, chickenpox, while hospitalized for a minor surgical procedure. Which intervention should the nurse implement first? A, place a mask on the child before transporting the child outside the room. B, immunize exposed family members with varicella vaccine. C, place a child in strict isolation to prevent outbreak on a unit. Or D, determine which staff had varicella before making assignments. And the correct answer is C, guys. Place the child on strict isolation to prevent an outbreak on the unit. Why? Because remember, when it comes to varicella, the patient is actually contagious 2 days before that rash appears. So you need to protect everybody else on the unit, right? Let's look at our other choices. A, placing a mask over them before transporting them out the room. Nope, you're not transporting them out the room. Nope. That doesn't do anything. B, immunize exposed family members with the varicella vaccine. Actually, only people who have not had the chicken pox before are at risk, okay? Choice C was the correct answer. You want to put them on strict isolation. And then choice D, determine which staff member have had varicella before making assignments. That's actually correct. You do want to do that, but if you have to choose between the strict isolation and assignments, it's going to be the strict isolation. You can worry about the assignments after you've made sure that you put that patient, on strict isolation. You're going to put them on strict isolation. Then, of course, when you're making the assignments, you have to find out who's had the chickenpox before, because only those patients can care. Only those nurses can care for that patient. And by the way, if a patient's pregnancy, guys, I can't speak, forgive me. If a patient is pregnant, right? That's a no. If a nurse is pregnant, it's a no-no. They cannot care for that patient with varicella. Next question. A child comes to the school nurse complaining of itching. Further assessment reveals that the child has impetigo. Which action should the nurse take? A, send the child home with parents to see the healthcare provider before returning to school. B, send the child home with the parents and report this to the healthcare provider. C, cover the lesion with dry gauze dressing and send the child back to class. D, wash the lesion with antimicrobial soap, air dry, and send the child back to class. Okay, guys, the correct answer is A. You're going to send that child home to the parents, and they can't come back until they have a note from the doctor. Why? Impetigo is a very, very, very contagious skin infection, okay? It's a staph infection, but it's very, very contagious. So they need to go see the doctor. They're going to get some topical antibiotics. And once they're not contagious anymore, they could come back to school. Look at our other choices. B, send the child home. Okay, we're good so far. You want to send them home with their parents and report it to the health department. No, that's not a communicable disease like gonorrhea or chlamydia or syphilis or AIDS. Those are reportable, right? Not impetigo. C, cover the lesion with dry gauze dressing and send the child back to class. No, absolutely not. And it's a child. What do you think the child's going to do? First of all, they're going to take it off to show it to all their friends, and they're going to spread that impetigo. So you're not going to do that. And then you have D, wash the lesion with antimicrobial soap, air dry, and send them back to class. No, no, no. They need to go home, go see the doctor, get some topical antibiotics, and come back when they're no longer contagious. Next question. A child has a nasogastric tube after surgery for acute appendicitis. The purpose of the tube is to A, maintain electrolyte balance, B, prevent the spread of infection, C, prevent abdominal distension, or D, maintain an accurate record of output. The correct answer is C, prevent abdominal distension. The whole reason that patient is getting the NG tube is because they want to decompress the stomach, okay? We want to decompress the stomach and also make sure that that patient doesn't get what we call stress ulcers, because guess what? Whether you have something in your tummy or not, your tummy is still producing hydrochloric acid. And if there's nothing inside of your tummy, what do you think that hydrochloric acid is going to eat up on? Your own stomach lining, okay? So the reason they put that NG tube in is for decompression. Next question. A child's admitted to the hospital for confirmation of a diagnosis of acute lymphoblastic leukemia. During the initial nursing assessment, which symptoms will the child most likely exhibit? A, bone pain and pallor. B, weakness and tremors. C, nystagmus and anorexia. Or D, fever and abdominal distension. Okay, guys, the correct answer is A, bone pain and pallor. And by far, this is the correct answer. This is what we see most commonly in the patient that has this type of leukemia. Now, you guys have to think about it. Why bone pain and pallor? Well, where are those blood cells being made? In the bone marrow. Those WBCs, those RBCs, they're being made in the bone marrow. So guess what? Those leukemic cells are attacking the bone. Of course they're going to have bone pain. Why do you think they're going to have pallor? Hello, didn't I just tell you that RBCs are made in the bone marrow? Guess what gives you that nice pink color when you have circulation? The RBCs. So instead of being nice and pink, you're going to be pale. So that is one of the most common symptoms that you see in the patient that has acute lymphoblastic leukemia. Bone pain and pallor. Next question. A child is rescued from a burning house and brought to the emergency room with partial thickness burns on the face and chest. Which action should the nurse implement first? A, insert an indwelling urinary catheter. B, administer IV pain medication. C, collect blood specimen for lab studies. Or D, assess the child's respiratory status. And the correct answer, guys, is D, assess the child's respiratory status, airway, okay? And when it comes to burns, the first thing you're going to make sure is that the patient can breathe. Because if a patient is a burn patient, there's chances that they inhaled those noxious chemicals such as smoke. You want to know what the noxious chemicals does to your airway? It causes constriction, and that patient's whole airway might just close up on them. So who cares about anything else if that patient can't breathe? And look at what they said to us in the question. They made sure, excuse me, guys. They made sure, let me go back to the question, that they told us that the patient had the burns where? on their face, so obviously they breathe in those noxious chemicals such as the smoke on their face and chest. So the chances are high that they breathe in that oxygen. Okay? You see these other choices? All of these other choices are absolutely correct. You want to do this for the patient, but it does not take priority over making sure that that patient has an established airway. All right? So when you get a question about a patient that had burns, you're going to be making sure that you're going to be assessing that patient. What are you going to be looking for? You're going to be looking for singed nasal hairs. If you see those singed nasal hairs, they breathe in that noxious chemical. You better make sure you have an airway kit at the bedside. You're going to be looking for singed eyebrows, right? You're going to be looking for that smoke dust on their mustache line. You better make sure you have an airway kit by the bedside. All right. So let's say we make sure airways taken care of, airways established. That patient's good on that front. Remember how I told you everything else is important? Let me tell you something. After airway, your two biggest concerns when it comes to a burn patient is dehydration and infection. Huge. Because what happens when a patient gets burned, especially on a large surface area, that's why you do that rule of nines, it causes a huge fluid shift. Okay? So all of the fluid, all of the blood that was circulating in the vessels, it now shifts out to the tissues, and that's why that person swells up. They swell up like a balloon because all that blood, all that fluid that was in the vessels is now out in the tissues. So guess what? Even though they look bloated, they're dehydrated, because when we're talking about fluid and electrolyte imbalance, we're really talking about how much is in the vessel, not how much is in the tissues. So those burn patients, they're going to be getting fluids because they're at high risk for dehydration. And guess what happens? If that patient gets extremely dehydrated, those organs start to shut down. That patient goes through hypovolemic shock. And the third concern is infection, guys. That patient's at great risk for infection because now you have these open wounds from the burn, and that's the perfect environment for bacteria to settle in. One more thing I have to address with you guys when it comes to burns: pain. I've taught this to you a million times. Pain never killed anybody. When it comes to pain, pain is very high on Maslow's hierarchy of needs. That's not a priority patient. That's not somebody you're running to, except for when that patient is in pain from burns. You have to medicate them because that pain can be so severe, it will threaten their physiological integrity. What else? Myocardial infarction. You have to give that patient morphine. You have to decrease the oxygen demand on that patient. And guess what? If they're in pain, their oxygen demand is going to go up. Who else? Any patient that has stones, kidney stones, calcium stones, struvite stones. I don't care what kind of stones that patient have. If they have stones, pain is a priority. And fourth kind of patient, sickle cell. If the patient has sickle cell and they are in pain, that is a priority. Okay? So outside of those four, I really can't think of those type of any other patients that you'd be running to, but those four. Okay? Anyone else? Pain never killed anyone. But sickle cell, burn, MI, and what's my third one? Stones. Yeah. That pain can be so severe, it can threaten that patient's physiological integrity and they can die. Okay? Where was I? Oh, I'm already at 28 minutes. Jeez. All right, I guess this is my last question, but guys, there's so much more that I want to cover with you. I feel like I haven't even touched the tips, so there's definitely going to be more videos coming, okay? Last question. A child with a permanent tracheostomy is confined to a wheelchair and is going to school for the first time tomorrow. During the school day, which intervention should be implemented for this child? A, cover the tracheostomy site with clothing so that the other children will not notice. B, apply suction for 30 seconds when inserting the stoma. When inserting a catheter into the stoma. C, discourage the child from coughing deeply to remove secretions. D, place suctioning supplies on the back of the wheelchair when transporting. And I'll give you a moment to think of your answer. And the correct answer is D, placing suctioning supplies in the back of the wheelchair when transporting. Our priority is always going to be what keeps that patient alive, okay? Our priority is always going to be what maintains the patient's physiologic integrity. And if you guys have been following me for a while, you guys have been watching my videos for a while, you will hear me say this over and over and over again, physiologic integrity, physiologic integrity. Guys, 75% of your test questions in school, that's what they're based off of. So if you don't know what falls into physiologic integrity, make sure that you guys watch my 11 tips to passing NCLEX. That video, make sure you watch it so you guys can get that down pat, okay? Let's look at our other choices so you guys can know why those are wrong. A, it says covering the tracheostomy site with clothing, wrong, so that children will not notice. Well, is that going to keep that patient alive? No. Matter of fact, that could cause complications, so you're going to get rid of that. All right? Also, physiological integrity is going to trump psychology, which means anxiety, fear, worried about being made fun of. Guess what? Physiologic integrity is going to be more important than that every single day of the week, so it's still wrong. Then you have B. Really? Look what B says. Apply suction for 30 seconds. Who are we going to apply suction 30 seconds for? We don't even do that for adults. Apply suction for 30 seconds when inserting a catheter into a stoma. Do we ever put suction on when we're going in? No. We suction when we're coming out, right? And for peds, we don't suction for more than 10 seconds. For adults, we'll suction 10, 15 seconds at the most, right? But peds, you're not suctioning for more than 10 seconds. And you're only doing it coming out, and you're only doing it intermittently, and you're only doing it in a circular motion. Some books say, let me back up, because some books say 10 to 15 seconds. So for peds, it's not going to be 15 seconds. It's not going to be more than 15 seconds. If you're suctioning coming out intermittently in a rotating fashion, it's not going to be for more than 15 seconds. 15 is going to be the max. So you're never going to do it going in, and it's never going to be 30 seconds. So that's wrong. Choice C, discourage a child from coughing deeply to remove mucus secretions. No, that's wrong as well. You want them removing those secretions. How you going to get them out? And then choice D, place suctioning. Oh, I went over that already. That's the correct answer, right? You want to get rid of those mucus plugs so that the patient can breathe, because who cares about anything else if your patient is not breathing? So guys, I have so much more to cover with you, and I promise you they are coming, but you guys are leaving me so many comments on the videos you want to see, and I'm trying my best to keep up. So with that being said, guys, I'm trying my best to bring out these videos. Please keep the comments coming. Thank you so much for the words of encouragement. Every time I see a comment below letting me know how my video helped you, it really warms my heart, and it just reminds me of why I'm doing this, guys. So once again, the videos are coming soon. Thank you so much for joining me, guys. If you have not done so already, please support this channel by liking and, more importantly, subscribing to this channel and sharing my videos with anyone you know that they will help them. Thank you so much, and I'll see you next time.